Hello everyone, welcome to my presentation. Today I'm going to discuss about the SARS-CoV-2 and enteric pathogen environmental surveillance Cox's Bazar and in Bangladesh and challenges and opportunities of this learned from this project. Wastewater-based environmental surveillance is an effective tool to detect a different type of enteric and respiratory disease causing pathogen. This surveillance system can detect different type of diseases in the environment before the onset of the clinical sign and symptom in the patient. It also helps to establish early warning system to notify the public health authorities of different disease transmission. Globally, there is a lack of information on the pathogen transmission in the environment, especially in the crisis situation like Rohingya refugee camp at Cox's Bazar, Bangladesh. Recently, studies found that different type of pathogens in the stool of Rohingya population, such as Vibrio cholera, enterotoxigenic Escherichia coli, and also Shigella. High concentration and prevalence of Escherichia coli is also found in different wastewater in Rohingya camp. However, there is no evidence on the systematic ways to detect this pathogen in and develop a wastewater-based environmental surveillance in the humanitarian settings around the globe. So the objective of this study was to design a systematic way to select the sample site, sampling strategy for the Rohingya camp and adjacent host community to detect and quantify SARS-CoV-2, rotavirus, Vibrio cholera, and Salmonella typhi. Uh, to monitor trend of different target pathogens, RNA and DNA, and concentration through quantitative PCR analysis. We also developed an effective strategy and for communicating with the different like stakeholders and disseminate the results of the surveillance system with different stakeholders. We also documented different type of challenges faced during the study period for this environmental surveillance system. We conducted this study in Rohingya camps for and host communities. Rohingya camps selection criteria was based on the wide geographical distribution of the samples. Uh, camp with high versus low population density, camp with high versus low prevalence of acute watery diarrhea. Host community was also selected from the municipality of the Cox's Bazar in Cox's Bazar district. So this was like a large collaboration between multiple stakeholders, Bangladesh government, and also like UN agencies and also national and international NGOs, such as WHO is the one of the biggest collaborator for this study, including UNHCR, WASH sector coordinator, WASH and health sector coordinators as well. And also we talked with the local government for this study to understand the pattern of the disease transmission and also like WASH situation in the camp and the host communities of the Cox's Bazar. We also conducted several visits to the camp and host communities to understand the drainage network, fecal sludge management, and the pathogen exposure to the population. We discussed with the camp in charge of different camps, field workers from DPHE and other WASH and health sector people, local representatives such as MAJI, and also we also analyzes different type of drainage and sanitation mapping for the camp and the host community that's shared by the local authorities. So after the scoping visit and discussion, we selected three camps, Camp 4 Extension, Camp 9, and Camp 15. So Camp 4 Extension had low population density with improved wash facilities, and Camp 9 and 15 had high population density with poor sanitation facilities. Sampling point for these studies were at the end of the drains, and a total of 9 sampling points were selected from these three camps for the weekly sample collection. And you can see in this picture the distribution of the samples in different camps. So these were the four target pathogens we have considered for this detection and the concentration of the pathogen for the development of the wastewater-based epidemiological surveillance. We collected 400 graph sample for this analysis, and we sent this sample to the ICDW laboratory using quantitative PCR method, and a total of 52 weeks of sample are collected for this assessment. Well, let's come to the results, and a total of 612 samples are collected from these three camps and the host community. And the highest prevalence were obtained for the rotavirus, followed by SARS-CoV-2 and Vibrio cholera. We also able to detect only 3% Salmonella typhi among these samples. So detection of the Salmonella typhi was least among this group. Let's see the distribution of different pathogens in the camps and also the municipal wastewater. Except for SARS-CoV-2, pathogen prevalence were higher in the municipal wastewater compared to the camp. Camp 4 extension, which was less populated and with improved wash facilities, had lower prevalence of rotavirus and Vibrio cholera detection compared to the other two camps, uh, where the population density were higher, particularly Camp 9 and Camp 15. The concentration also follow the trends of the detection, and the highest concentration was obtained for the Vibrio cholera, for the rotavirus, and the detection was low in Camp 4 extension. You can see in this picture. The In this picture, the concentration also like highest in for the SARS-CoV-2 and the Vibrio cholera. The Salmonella typhi concentration was least among the group, and also is follow the similar trend of the detection of the Salmonella typhi. This line diagram is providing information related to the monthly detection of the pathogens in camps and community, like municipality. The light blue lines representing the municipality pathogen detection percentage, and the dark blue line is representing the monthly pathogen detection in the Rohingya camps. The detection trend was similar in both municipality and the camps, camp wastewater, except for rotavirus, and the percentage of Vibrio cholera was less during the winter season between December to February, and also peak during the summer season. And here the rotavirus actually is decreased in the camp between July to October, July to September 2023 in the camp area, but the host community it was like consistently high. There was a significant positive correlation between mean Vibrio cholera concentration and weekly acute watery diarrhea patient in each camp. A positive correlation indicates that whenever the concentration of Vibrio cholera rise in the wastewater, the acute watery diarrhea increase also in the community. So challenges we faced mostly the coordination between the intersectoral coordination, and also like sharing the data was the most important challenge from the starting of the study, and also like specific site specific GIS mapping was also not available to track the drainage and also like sanitation facilities and how the fish is actually going from one area to the another area. So exposure is not that much easy to actually track in this area. Quality of acute watery diarrhea is also not that much because it's also not laboratory confirmed acute watery diarrhea or pathogen detection for this study. So finally, like it has a big impact in the camp, although national level, this type of surveillance system, and people are really sensitized, particularly policymakers are aware of a new way to identify and investigate the disease hotspot in the refugee camp and the neighboring municipality. People are also influenced by this study, and health and city authorities are interested in this broader benefit of the wastewater surveillance to inform decision making about the infrastructure and investment. So also like these results have to to raise awareness among the stakeholders about emerging pathogens, AMR, climate-sensitive pathogen as well. Ability of quality disease-specific clinical data can improve this wastewater surveillance more accurate prediction for the future pandemics and other things. And finally, like long-term sample follow-up and also like continuous funding for this type of study is very crucial uh, for seasonal variation, temporal trends, and also this type of surveillance can help health authorities to make future decision making very accurately. So these are our collaborators. This is a big collaborators between government, non-government, and UN agencies. We'd like to thank our donor, like Rockefeller Foundation, to funding this project, as well as our support from the core donor for this funding. Thank you for your patient sharing.